Hi, I'm Frank Diamond, the managing editor of Infection Control Today, where we're giving infection preventionists and other healthcare professionals the information they need to battle COVID-19. But COVID-19 won't be the main topic today, although it will certainly be mentioned. You can't have a discussion about healthcare these days without mentioning COVID. It sucks all the air out of the room. But non-COVID healthcare goes on. It has to go on or we're in trouble. It's been stalled, for sure, and set aside when COVID peaks, but routine care and elective and non-elective surgeries for problems that have nothing to do with COVID must continue, or our collective healthcare gets that much worse. Which brings me to my guest today, Dr. Nancy Moureau. We here at Infection Control Today are lucky because Dr. Moureau is on our editorial advisory board. Dr. Moureau is an internationally known healthcare expert. She's an expert about a lot of things in healthcare, but primarily, I guess you'd have to say, peripherally inserted central catheter lines, or PICC lines. Dr. Moureau, back in May, wrote an article for Infection Control Today about the establishment of PICC teams, about how the job is evolving from the PICC nurse into the PICC team. Dr. Moureau, thanks for being with us here today.
It's a pleasure to be with you. Thank you for the invitation and the opportunity to talk about some subjects that I feel are very pertinent to the care of patients and to really promoting safety within the treatments that are necessary for our COVID-19 patients.
Okay, so in your work as a consultant, you mentioned in your article that there seems to be an evolution from the PICC nurse to the PICC teams. Do you see that still going on, or you see that proceeding, or do you see that has to happen?
Yeah, we're definitely seeing a transition from a focus on PICC lines to a focus more generally across the vascular access devices. Because of the advent of ultrasound and the ability to pick other choices from central venous catheters, PICC lines, peripheral catheters, long peripheral catheters, midlines, what we're finding is the need for specialists to be able to make those decisions, and not only make those informed decisions, but also to place these in a manner that is the most successful and the safest. And when we think about success, it's not only being able to put in the right device at the right time, but also by the right person. And in terms of administration, being successful with a vascular access insertion on the first attempt also translates to significant savings because you're not using multiple catheters, you're not using more supplies. And also we have to factor in, especially for our COVID-19 patients, the savings in terms of time and efficiency.
When you say a PICC team, who would comprise the PICC team? And two-part question: would an infection preventionist be part of the PICC team?
Yeah, so really we're calling it more of a vascular access specialist or vascular access team. And similar to infection preventionists, what we've discovered is that having a vascular access specialist available in the hospital, in all hospitals, has been essential for our COVID-19 patients. So a patient comes into the emergency room and gets emergent access, but yet this patient may be long-term. If the patient continues on to the intensive care area, then in fact they may need a central line placed and have it placed very quickly. We have various recommendations that have been issued by some international groups, specifically Dr. Pitteruti and Dr. Scopitulo, providing us with some guidance on which devices are most efficient for our patients. And it's determined by where they go for first placement or first admission, whether they go to an intensive care area or they go to the regular medical floor. And in the case of the intensive care, we have to consider the different types of central lines. And for those that are not quite as emergent, you still likely need an ultrasound-guided long peripheral catheter that will last for a longer period of time rather than facing lots of these devices. So the transition from the term PICC team to vascular access team or vascular access specialist team is definitely happening. And what we've seen throughout hospitals in the United States as they step up in order to manage the COVID-19 emergent situations and intensity of treatment is that they've been first online in order to place these lines and place them in such a way that they can be used for treatment immediately and the patient has long-term use.
The vascular access teams, you've been getting obviously a lot of questions since COVID arrived. You're a well-known expert. How do they separate the treatment for COVID patients from non-COVID patients, or do they just assume that everybody could possibly have COVID?
Yeah, so, you know, that's kind of a chicken or egg thing because patients come into the hospital with symptoms and they're going to have to determine whether it's a COVID-19 patient. And so the differentiation has been suspected COVID-19 patient versus confirmed COVID-19 patients. For those patients who are not COVID positive and simply have other types of symptoms, a vascular access specialist it provides a level of safety that the generalist nurse doesn't have. The evidence that we have supporting that is from Dr. Marsh at Australia with the AVATAR team, the Alliance for Vascular Access Training and Research, and more evidence by Dr. Peter Carr and others, and even in a Cochrane review that looks at these teams as an essential element of all hospital patients or all hospitals in order to provide a high quality of service for their patients. And it's not just quality, it's safety, and it's the fiscal responsibility. So there are multiple factors involved that don't just lend itself to the luxury of having a vascular access specialist. It now is more of an essential component of any high functioning hospital.
You're using the term vascular access specialist and vascular access team. Uh, I'm taking it they're not one and the same. So somebody would be working with the vascular access specialist, and who might that be?
So when I use the term vascular access specialist, I'm thinking more as an individual, whereas a vascular access team may be comprised of multiple specialists. Multiple people who have special training. We know from the Centers for Disease Control in their prior recommendations, they show that by having a specially trained person for device insertion, you reduce infections, you reduce complications overall. We've also seen this in some of the literature. Um, the PIV5 rights research that was published by Lee Steer out of Connecticut and others who have shown that by using specialists or using specialist teams to address the issue of peripheral and central access, that they get much better outcomes and a considerable savings for the hospital. The Hartford Hospital in Connecticut that I just referenced with the PIV5 rights saw a huge savings as they expanded their vascular access team and allowed them to take over all peripheral access for all patients. And so that's the kind of evidence that we need to show that the vascular access specialist as an individual or vascular access team, the larger hospitals, is necessary for hospitals in order to provide the level of care that patients deserve and need.
How, we've all noticed the reallocation of healthcare resources as a result of COVID. Like we had to put a fire out over here and a fire out over there, and people who usually don't do the things that they're asked them to do have to do it. Do you see yourself in some ways being an advocate for vascular access teams in the sense that maybe a hospital or health institution will say, well, that's not our priority at the moment. We need to shift them from over here to over there, or put less focus on them, or put less resources into it?
Yeah, so one of the questions that you asked me earlier that I didn't fully address was, how does the vascular access specialist or team work together with the infection preventionist? And when you talk about where priorities should be and where allocations could be, of course, our priority is to minimize infections or potentially even to eliminate them. Um, we want complications to be history. Um, and so in order to achieve those goals, I see it as a partnership with the infection preventionist, working with the vascular access specialists and teams in order to implement guidelines, recommendations, provide education to those who are at the bedside to make sure that everyone is following policies and best practices to the level that is necessary in order to achieve our goals. A single infection preventionist or a smaller department is unable to do that. Their focus is not only on central line associated bloodstream infections, but also urinary tract infections that are associated with urinary catheters, with ventilator associated pneumonia. And so there are many, many things that are on their list that must be prioritized. So aligning and partnering with these different specialty groups, with the different departments that can help to implement the guidelines and make sure that things are followed well, help us all to achieve the better outcomes to reduce complications and make things better for patients.
Dr. Nancy Moureau, thank you so much for being with us here today at Infection Control Today, and thank you also for being on our editorial advisory board. As always, a fascinating discussion with you.
My pleasure. Thank you very much.